So as you noticed in the introduction to this video, with the text on the screen, the multiple descriptions that Dr. Still gave of working on the clavicle, remember, pause to read. If you didn't pause to read, go back, pause to read them, and then you'll see where all of what I'm going to show you is coming from. So we're not simply going to show you what Dr. Still said, we're going to make sure that you understand the concept with description that would guide how to generate these methods, or guide how to describe them so that you understand how they're all the same. The primary way that these are all the same is the concept of relational motion. So Dr. Still does not speak much about the SC joint. One of the quirks about the SC joint is that although it has a fair amount of motion, it isn't necessarily easily manipulated, right? So when he's talking about the SC joints, he talks about springing them, basically just pushing. So you can do it with both hands. You basically just push the shoulders down onto the table. In an ideal sense, you'd have enough movement on the table, and if you look at some old tables, they actually have a pitch to them, so there's a fairly flat spot in the middle and then a pitch to them, so it would actually be easier to do this on a table with a pitch, but then the patient's more likely to fall off, and that's annoying. But he would talk about springing both of them by pushing down. If you don't have to spring one of them, if you've checked and you don't have to spring one of them, you can palpate the side and push down on that side. So you just go to the region of the SC joint, palpate, and push it down. That's one of the ways he talks about the SC joint. The other way he talks about it is lifting it away essentially from the sternum, from the ribs. He doesn't tell you how to do that, so you can essentially do some short lever version or a long lever version. The short lever version would basically mean pulling the shoulder up away from the table. So you grab the shoulder, palpate at the SC, and you can pull it up that way. But you can see my patient just rolls, right? That doesn't work as well as I want it to. So then you get something like this. You use the arm as a lever, and you can pull the arm away, because that's actually going to get more scapular motion, which is then going to indicate that the SC can move farther. So you can just pull it straight away. If you pull it away and you want to do a little bit more, you have to be careful because of where the brachial plexus passes, and you can make this very annoying, but you can hook slightly behind the clavicle, very, very medial. You have to also consider where the heel of your hand is in many patients, because they won't be uncomfortable because your hand is going to move down their chest wall. But you can come here and you can do an extra lift. Now he would talk about making sure that the opposite shoulder was stabilized sometimes by a patient, but you can just pull up. So relational motion here. Relatively still thorax, moving clavicle. So I keep the thorax still, I push the clavicle backwards or the shoulder backwards to spring the SC joint up. I lift the arm up to pull on the clavicle to move it away from the relatively still chest. So relational motion is the deal there. If you can see this hold, lots of contact for control, broad contact for multi-point discrimination, as we've talked about in previous videos. He does talk a lot about the AC joint. The AC joint, again, now it's, instead of still thorax moving clavicle, it's going to be still clavicle moving scapula, right? So he talks about basically hooking behind the lateral third of the clavicle. Once you hook there, you can push the arm straight back to the table. So he talks about doing this from time to time if it's on a bed and not a table, with a book between the shoulder blades to essentially stabilize the patient a little bit. But he talks about hooking behind the AC joint or behind the clavicle and pushing the scapula back, right? So still clavicle, moving scapula. Talks about bring the arm up and towards the patient's face in an arc. Still clavicle, right? So you're hooking behind, it's a still clavicle or relatively still clavicle, moving scapula. By moving the arm, you're essentially moving the scapula. He talks about being able to hook there again, right? You hook behind the clavicle, the lateral third, and you can draw the arm backwards, right? Draw the arm towards the floor. Again, still clavicle, moving scapula in a relative sense. He does talk about using your femur as a wedge or a fulcrum in the axilla. You don't necessarily want to stick it into the axilla because that doesn't do anything for you. you want to stick it slightly behind the shoulder, right? So you keep the clavicle still, move the arm back, you've got a fulcrum to move the arm back, and essentially lever the scapula, again, in relation to that still clavicle. When he talks about his standing methods, or his patient standing or his patient seated methods, so we'll just have you sit on the stool with your back against the wall. So it's going to be harder to see just on account of how the shot is set up, but he's talking about stabilizing, right? So you push against their shoulder, you push them against the wall so that they're nice and stable. Again, you hook behind the clavicle, right? You can stabilize under some circumstances. You can put your hand on their sternum, right? You can put your hand on their sternum, but essentially, again, relatively still clavicle, holding behind that third, drawing towards the face and around, right? So you're just using the wall, whether the patient's standing or sitting, to stabilize the patient. So contact is control, control is safety. Less stable means I need to make the patient stable. Now in this case, instead of the patient being on a table, you're using the wall to control the patient, be it a door jamb, be it a wall, be the patient sitting or standing. But all of these are united by relational motion. One thing stays still, one thing moves in relation to it. The thing that is staying still with the SC is the thorax. So the thorax stays still, and you move the clavicle in relation to a still thorax. The AC, the clavicle is still, and you move the scapula in relation to the still clavicle, and the way that you usually do that is with an arcing motion of the arm. The arcing motion of the arm moves the scapula.